Good morning, everyone. We'll get started in just a few minutes. We'll give people a few more minutes to connect. Thank you. Good morning, good afternoon, good evening, everyone. We'll get started in one more minute. Thank you. All right, well, good morning, good evening. Thank you everyone for joining the June Global Digital Health Network monthly meeting. I'm Steve Allis, the co-chairs of the Global Digital Health Network, and today we'll be hearing about Kenya's COVID-19 electronic tracking solutions presented by Palladium. I'm going to go ahead and turn it over to Rose to introduce the speakers, and we can begin the presentation. Please type your questions into the chat box as we go, and we'll have time to take them as we run. Thank you very much. Rose, over to you. Hi, Rose, over to you. Okay, looks like Rose is having a small technical difficulty. Jacob, we have you up as the first speaker. Can we go ahead and take it over to you and ask you to begin the presentation?
Hello, Steve. My apologies. Yeah, good morning, good afternoon, good evening, everybody. My apologies, my call dropped for a few seconds there. So I'm going to introduce the topic of our discussion today. So as we all are aware, COVID-19 has changed how business is conducted world over. Governments have needed data to help inform intervention design. They have needed data to help inform how the response is managed. However, in resource limited settings where most of our operations are, that have been developed primarily through PEPFAR support. This data for COVID, however, requires data sources that are varied and outside health facilities. So you need to bring in data from ports of entry, from quarantine centers, some of which are hotels and schools, from national public health labs, from treatment centers, some of which are existing health facilities, others are makeshift facilities, and from the community e.t.c. And for us to be able to bring on board data from disparate systems and be able to have this data sharing, data from these sources being shared across systems to inform the government in making decisions, you need to have interoperable systems or interoperable solutions. Global goods and adapt or reuse open source systems that have previously been deployed in HIV programs successfully. So in this presentation, we will be looking at our experience as Palladium in 2 countries where we have implemented HIS strengthening programs for over 10 years. One is Kenya and the other one is Nigeria. So in the case of Kenya, we will look at how Palladium has worked with the government to be able to curate and assess existing digital solutions and identify which ones provide the best fit, and how we've been able to develop and deploy one open source system that has been deployed in HIV care in over 1,000 facilities and adapt it for use in COVID-19 tracking. We will look at an overview of the data sources, the various systems, and how they are able to share data. Then we'll move on to share what our challenges have been and the lessons that we've learned. Then we'll go on to share about our experience in Nigeria. In Nigeria, we have a USAID project we refer to as DataFi, and it's USAID mission's primary SI mechanism for strengthening HIS to support HIV programming. Because of the changes that have been brought about because of COVID-19, this project has had to adapt its programming and include in its programming development and deployment of digital solutions for COVID-19 data management. So in this case, we will look at how the project has adapted its implementation plans under the emerging realities, how it has reused widely available technology for seamless delivery of its mandate, the lessons that the project has learned, and how this can be leveraged in similar projects to adapt to the new realities. Then we'll move on to Q&A and look at experience sharing for perhaps other people or partners that have had experience in the COVID-19 tracking solution space. So we will start with the case study for Kenya, and this will be presented by Dr. Jacob Odhiambo. Over to you, Dr. Jacob.
Yes, thank you, Ross, for that. Yes, so I'll take you through the next the next like 15 minutes or so on Kenya's experience with COVID-19. In the next slide, you'll see please move the next slide, please. In the next slide, you'll see how our project has implemented COVID-19 applications in partnership with other partners. So according to the overview that's on the left-hand side of your screen, the first case of SARS-CoV-2 infection in Kenya was detected on 13th March 2020. And since then, we have had an upwards trajectory like in many countries with around 6,000 cases currently reported. There are a few counties that have emerged as a hotspot, and we'll see that as we proceed with the presentation. In the next slide, you'll see that, just go ahead to the next slide, please. So in the next slide, in this slide, you see kind of the steps that Kenya follows in investigating its cases. In step one, alerts may be received from the points of entry or in the community. Once the alerts are raised, in step 2A, the rapid response team responds to this by filling in a case investigation and lab request form. These are currently handled electronically using two applications, the COVID-19 app that is based on the Community Health Toolkit. It allows for offline data capture in remote parts of the country and synchronizes the data to Kenya EMR. Kenya EMR is used by surveillance teams in the office from where they review the cases and look at the download line lists, review line lists, and also allocate tasks. The data from the case investigation is synchronized electronically to the laboratory management information system. Once again, an open source application developed within Kenya. The samples are transported by courier to follow the electronic record in the system. And once in the lab, the specimen is processed by the machines and that push the data electronically back to Kenya EMR and the COVID-19 app. Once the positive case is isolated, it's in step 2B, then a contact listing process follows up. Once again, the COVID-19 app and Kenya EMR are used for contact listing if the individual is either in the community or in an institution. Now, for some contacts, the moment an individual is listed as a contact, then they will consent to receiving SMSs from the EOC. The first SMS is sent through an app called JKUAT, that is the fourth application that I'll be introducing to you today. JKUAT is used for self-monitoring, where the individual may shelter in place at home. And during that period, they will be reminded to be self-reporting on any constitutional symptoms of COVID-19 that they may develop. Now, travelers coming into the country, mainly the crew of cargo planes and trucks, may be required to be on quarantine for a period of 14 days. In some cases, some contacts are also required to be in quarantine, either at an institution or at home. So those who are in institutional quarantine facilities, Kenya EMR has a quarantine management module that allows quarantine staff to admit, follow up, and also discharge individuals who are on quarantine. And in case they develop symptoms, then a case investigation form can be filled right from Kenya EMR. Now, JKUAT app was added to the quarantine facilities to allow the exposed individuals to self-report on their symptoms without having to expose a healthcare provider to them. So basically to reduce the risk for the quarantine staff, but also to allow self-monitoring. All the applications in step 4 generate strategic information in the form of line list dashboards and situation awareness report are different for targeting different individuals who use these applications. But we also have a public portal based on the ArcGIS platform developed by our sister university, JKUAT, and we are able to basically view the data alongside the models for the country in that portal. In the next slide, please proceed. You'll see how CHT looks like. This is a few screenshots to show you how CHT looks like. On the left-hand side is a case that has been investigated. And this is just a summary of what the provider sees. And at the bottom, you'll notice they are alerted that the lab team will be notified of that case. In the center, you'll see the contact tracing. This is a contact with a number of cases registered under them. And then you can just choose any of the cases of the contacts and undertake certain actions. On the right-hand side, you will see a contact has been selected, and then the individual can be followed up over time. And of course, you can see additional forms for travelers available in the application. In the next slide, once data has been shared, put in the entered into the app, you'll please just press next again so that the screen can show up. So once the case has been synchronized to Kenya EMR, this is the screen that the surveillance teams will view. There is on the left-hand side a yellow alert that indicates that this is a positive COVID-19 case, but they'll be able to view the registration and travel history, the case investigation details, which can be expanded to expose the whole case profile. But also if the individual has been on quarantine, they are able to view the information about the dates of admission and discharge. On the right-hand side, you can view any follow-up lab orders and contact listings can be entered through Kenya EMR in case not all contacts were listed from the app. In the center, the comorbidities and follow-up information can be viewed. In the next slide then, we'll now go to the self-monitoring, just a view of what happens. The moment an individual is listed as a contact, they'll receive an SMS to download the app. It's an Android app that's available on Play Store. Upon download, the users are prompted daily by SMS to report any constitutional signs. They can do this twice a day. If they have a thermogun, the system will prompt them to check if they have a thermogun. And every day they're able to enter their temperature and and report if they have developed any symptoms. If they fail to report, the surveillance officer is notified by SMS and reminded to call them and ensure that they self-report. So the next part of the presentation, in the next slide, will just be about some of the achievements and lessons we have learned. So most of the solutions we are presenting to you today were repurposed from HIV-centric applications. So they were already being used. Healthcare workers were familiar with them in the HIV space, but they have been adopted for use for COVID-19. What this did, it allowed us to faster turnaround time. Within a period of 3 to 4 weeks, we were able to have a minimum viable product that has been undergoing improvements as the program, the surveillance system mature. We had the challenge of movement restriction, and for this, we hosted this application centrally and enabled secure access with the role-based access controls that allowed county surveillance team not only to report, but only have access to the data that belongs to their county and that they're entitled to view. Since Palladium also implement the largest HIV program information solution project in Kenya, we also managed to ensure that the business continues HIV-centric applications by hosting a national data warehouse centrally that allowed facilities to report on a regular basis on what was going on. And I'll be giving you information about that in the next few slides. Next slide, please. Yes, so some of the things that we made sure we worked closely with the Ministry of Health to achieve is to ensure that standardized data sets were used so that the tools that were on paper are the ones that were digitized for the purposes of monitoring the epidemic. The validations were built in with guidance from the Ministry of Health and involvement of the end users to ensure that they were aligned to their business processes. There is regular data review and data management, and an oversight teams continuously looks at the data. Then the data and unique identification is a big problem in many African countries. The Ministry of Health adopted the use of the national ID for adults and a combination of the parent's ID and the serial number for children. The next slide. There's been a number of data triangulation activities ongoing in the country for COVID-19. The denominator, of course, is the population of the country. So census data has been used to just know how many cases we're having per county, per 100,000 population. Right at the top, of course, is the data from the COVID-19 tracking application, the lab management information system, and the national data warehouse, to just ensure that data that is being collected through the applications are providing data that is within reasonable bounds, but also to get a bit more information about subpopulation that we are managing. I'll give an example in the next few slides about the national data warehouse, but also for this. Before we move to the next slide, just want to highlight one specific thing about it. So to get in partnership with Jomo Kenyatta University of Agriculture, we have and technology, we have been able to triangulate data being collected for surveillance, but also disease projection modeling, disease projection models to just make sure that we are able to inform the Ministry of Health about the trajectory the epidemic is taking vis-a-vis the cases that we are identifying. The second part of this is about supporting policy decisions on HIV patients. So we conducted an analysis that I'll be taking you briefly through. Just look at workload at health facilities vis-a-vis the need for to decongest these facilities, through multi-month dispensing commodities to reduce the number of patients who visit clinics on a regular basis to seek refills of antiretroviral commodities. So in the next few slides, you'll be able to see how this played out. Next slide, please. So one last piece of technology that I just want to show is this dashboard that was developed in partnership with the Jomo Kenyatta University of Agriculture and Technology. So the dashboard basically is used to monitor the cases that as they come daily. But it is, if you look at the top, the blue band at the top, you'll also see the prediction model is integrated with it. So we are able to compare the model side by side with the number of cases being diagnosed, so that we are fully aware about what's going on in the country and can brief the Ministry of Health on that. In the next slide, then you'll see just a couple of slides just about our case trajectory as at 24th of June. And in the next slide, I think the map you have seen in the previous slide, so I will not dwell on it. Just go ahead. Next slide, please. Next slide. So just looking at HIV and HIV care. So if you just go to the next slide, you will see how, just keep going please so that all the maps load. It's two more. Yes, so you'll see quite a number of facilities. Keep going please. You'll see a number of facilities that implement health information systems for HIV response. We have a total of 1,114 facilities that are implemented in Kenya. Out of these, 372 use Kenya EMR already. And over 50% of patients who are receiving HIV care are seen at these facilities. So in the next slide, then you'll see that together with this, we have a national data warehouse. The national data warehouse has data on over 652,000 active patients on ARVs out of 1.1 million patients on ARV in Kenya. So a number of questions emerged that the routine aggregate reports could not answer. What is the risk of severe disease among HIV-infected population? So the warehouse was providing answers to this because of the number of patients whose individual level data we had that included their age, their sex, their comorbidities, their viral load suppression, among other features. And from other countries, we know that COVID-19 is severe risk among people with comorbidities. Generally, people above 40 years old tend to have a higher rate of comorbidities than others. And then, of course, individuals in the age of 60 years and above, you can just move to the next slide, over 60 years have a higher risk of severe disease among COVID-19. So the next thing was about, okay, so what do we do among these individuals? Then we looked at the appointment duration for these persons with an aim of seeing what are the opportunities for decongesting HIV clinics. We found some clinics seeing an average of 300 patients per day, while others were seeing as low as 20, even if they had the same number of patients. And the difference was the number of months of appointment that were being issued to these patients. So we looked at, first of all, what is the stability status of this patient and how many months of appointments were they being given? And we noticed that a large number of patients who fit in the lower two parts of the the component chart were being given less than 2 months appointment, even if they were stable. The ideal situation was to give them longer appointments so that they do not have unnecessary exposure to health facilities and also to other patients whose COVID-19 status they may not know. So through using this data, we were able to advise the Ministry of Health to send a circular out advising facilities to give longer term appointments as part of the COVID-19 prevention measures. And this has been acted on. We are currently doing a data review 3 months down the line to see how facilities have responded to this in terms of the kind of appointments they are giving to patients. Next slide, please. Next slide. Yes, so currently ongoing activities is sustained rollout of the COVID-19 surveillance system as new counties report cases. Is supporting the Ministry of Health to transition to these solutions for their daily situation report generation as counties come on board. And then we are currently doing an analysis of comorbidity data just to complete the picture about the risk that HIV positive individuals are having when it comes to COVID-19. We know that over 93% of cases are virally suppressed, which means that the risk is much lower than we expected. But the rate of comorbidities is under analysis to just figure out which individuals are at risk and in which parts of the country so that they can be protected. Modeling, we are working with Jomo Kenyatta University to continuously give the ministry briefs on the hotspots. There is case management module that is being developed currently. And then there's continued remote technical support for the COVID-19 solutions. Next slide, please. Next slide. Yeah, so we have learned a lot of lessons. Government leadership, ownership, and coordination is critical for sustainability. The epidemic has been evolving rapidly with interventions being adjusted on the go. And we have had to respond to this with the kind of agility it requires. HIV has been lessons learned from HIV have been very instrumental in implementation of COVID-19 applications, not just during the development phase, but also during rollout. Reuse of public health goods, the digital public goods have been very important because it allowed time savings and cost savings that otherwise we would not have benefited for. Then the enhancement that we have done for COVID-19 eventually will come back to take care of the HIV patients that we are also handling on the other side. So I think in the next slide, this should be the last one. Will just be to hand over to acknowledge the colleagues we have worked with from other organizations, but also hand over to Ross, back to Ross, to introduce the Nigeria DataFi team for the next part of the presentation. Over.
Great.
Thank you very much, Dr. Jacob. In the interest of time, we shall move on to Dr. Dauda with the Nigeria case. So
And
please
actually,
load the slides.
Rose, let's take one moment. We did have a question come in for Dr. Jacob. Thank you for that presentation. The question was, for the systems that were described, what is the level of interoperability between all these systems?
Could you please just clarify the question so that I respond to it?
Sure. Came in while you were describing all of the different systems that were involved in the response. And so the question was, what is the level of interoperability with these systems? Okay, looks like we're having some audio challenges, so we'll move on to the next speaker and we'll see if we can take that in the Q&A. Dr. Dowda, that's over to you.
Yeah, thank you. Good morning, afternoon, or evening, everyone. I'm Dawda Suleiman Dawda, Country Director for DataFi Nigeria. And this presentation is going to be looking at how we have been able to pivot on widely available technology to ensure seamless continuation of our work under COVID-19. Next slide, please. Thank you. So just a little background before we proceed. Nigeria is the first buy-in on the global 5-year DataFi cooperative agreement with USAID. And the goal is to accelerate and sustain access to high quality data to expedite HIV epidemic control and maintenance. Currently, we have 3 major streams of work in Nigeria. First being USAID performance management, where we make high quality, timely and compelling data and analysis available to the Nigeria strategic information and HIV officers at the mission to aid in their strategic planning and evidence-based decision-making for managing the PEPFAR program in Nigeria. So this is mainly facilitated by our activities on the second stream, which where we provide real-time visualizations on the automated partner performance reporting platform, the APPR, pulling data, which pulls data from the PEPFAR implementing partners, high-frequency reporting, and other data sources such as the National Data Repository, national level census, particularly the NICE survey of 2018, and the electronic medical record systems of implementing partners in Nigeria. So under this activity, we are also supporting the setup and institutionalization of epidemic control rooms, with the first of these epidemic control rooms set up in Akwa Ibom State, which is the state with the highest HIV prevalence in Nigeria, and naturally a PEPFAR surge state. The third stream is support for health informatics systems development. Here, alongside the mission, we co-led in the development, in the formation of a community of practice, which is here working to support USAID Nigeria PEPFAR implementing partners to develop health informatics solutions, mainly the open source LAMIS Plus electronic medical record system, also developing the APPR, which pulls the weekly partner reports from the HFR, and also integrating of the systems of the implementing partners with the Nigeria's National Data Repository and the Logistics Information Management System. Next slide. So next slide, please. Yeah, so here we have a snapshot of the epidemic control room in Akwa Ibom State, where we have weekly data review meetings. Here we coordinate in collaboration with the State Ministry of Health, the State Agency for the Control of AIDS and other agencies. And we have attendance from USAID, implementing partners and other stakeholders involved in the HIV response in the state. In subsequent slides, we shall be looking at how DataFi has successfully pivoted on available technologies to continue to support this type of activity and others to give stakeholders access to data and continuous data use. Next slide. So to ensure that all stakeholders continue to have access to the data, we have done 3 things. First, we have automated pull of data from partner systems to populate the HFR, the high frequency reporting system, which eliminates the time-intensive step of manually importing the data from these partner systems. Secondly, we institutionalized remote data reviews. So for example, the data review meetings we saw in the previous slide are now being held virtually. They are being held online with the aid of widely available platforms such as GoToMeeting, Skype, or Zoom, and Microsoft Teams. And then lastly, we are using these same platforms to facilitate weekly discussions on performance with implementing partners. Thus, we continue to identify the low-performing partners on USAID and PEPFAR programs, and look towards proposing strategies to identify, to address the gaps that have been identified in their programs. Next. So at the center of our work under the third stream is the development of the open source modular electronic medical record system that is built to Nigeria's specifications, which is called LAMIS Plus. And for seamless progression of the software development cycle here, we are leveraging on a range of applications aimed at ensuring smooth communication and collaboration across our staff on DataFi, the implementing partners, on the community of practice, and regional technical experts, despite the quarantine conditions in Nigeria. So we continue to use GoToMeeting, Microsoft Teams, Skype, and other web applications for meetings, online meetings between the programmers. The software development cycle is being constantly monitored on Jira. The programmers in between themselves use Slack for interagency communication, as well as the use of GitHub for sharing of the codes as they progress with the development of the software. Next slide. So with the advent of COVID also, we got some funding from USAID to support COVID response in 8 states across the country. And we worked with other implementing partners to set up similar emergency operation centers like we have for HIV in Akwa Ibom. So we set up emergency operation centers for monitoring the COVID response across these 8 states. We are working with those 8 states to look at the data that is being generated for the COVID response. In Nigeria, we're using the SOMAS application as a national system to manage the response. And so we are triangulating data from both the SOMAS platform that we have working across these states, as well as data from other sources to seek to answer questions that may arise, and also questions that the state teams may have to enable them effectively manage their responses. Some of the questions we seek to answer include linking mobility data to disease mortality. Also, we are looking at how quarantine measures impact transmission rates across the states, how populations have access to grocery stores, workplaces, transit stations, and retail centers despite lockdowns and quarantine situations that are currently in place in most of the states in Nigeria. And also, we are monitoring how COVID infection rates impact the population access to healthcare, particularly in facilities where HIV care is being provided, and how that affects retention of clients in care. So for this, we are, as I mentioned, using data from different sources from the PEPFAR, high frequency reporting, and mirror platforms, the SOMAS data, as well as data from open sources like the Google mobility data to capture movements in the general population. With this, I think we've come to the end of the presentation. We'll be happy to answer any questions or comments that you have. Thank you.
Great. Thank you both for those wonderful presentations. So we have a few questions we're opening it up now for questions. You can type your questions in the Q&A box. So I see, so the first question we have here for our panelists are, what is the level of interoperability of all these systems? So Dr. Jacob, it looked like you wanted to answer this one.
Yeah, so I can just respond to that. I'm not sure I answered what I got what they meant by the level of interoperability. Perhaps if we could just clarify that, then I'll just respond comprehensively. But just from our standpoint, is that the data set that has been identified about, the case profile, the demographics of that case, the surveillance information that is captured as part of the case profile. So you provide the demographics of the person, and then there's some epidemiological parameters that is captured as part of that case. And this is shared with the EMR. So within the EMR, then you can be able to see a summary of both the clinical and the demographic part of that case, including their travel, their kind of contacts they've had with others. It's quite a comprehensive payload that is sent to the electronic medical record system. But now for the lab, the laboratory just gets what they require for the testing, the basics of the demographics and the identifiers, and a summary of a subset of the data that they require to identify the specimen, but to conduct the test as well. So I don't know if that answers your question. Yeah, just to respond to that first question. Over.
Thank you. So our next question is also for you, Dr. Jacob. So can you share specific contact tracing data sets being collected from infected persons? So I guess the question is if you're able to share those, the contact tracing data sets.
Sure, we can share that separately. If you can get the email address of FOLA, we can share the data set. But we have, of course, the usual demographics. We collect the information about the residence of the person, their phone numbers, and the type of exposure they have had to the index case. And this is basically used for not only to identify the case, to contact them, but also to trace them physically or by phone. So I can share that in a separate email.
Okay. Fola, if you could type your email address into the chat to the panelists, we'll send that to you. All right, another question from Fola. Let me read that. Is there an ideal data set for COVID-19 contact tracing globally or specific to the African continent?
Yeah, so the WHO has a data set that, like kind of a data set that they require, the minimum data set for contact tracing. They had a set of tools that right from the beginning of the outbreak in China, they had recommended for contact tracing. And that is what Kenya adopted and kind of modified or customized for our setting and has been in use since that time. There are, of course, elements in the data set that were very specific to the outbreak in China that we had to remove from the data set to allow us to allow it to be a bit more useful for our setting. Yeah, so there is actually a data set that WHO had recommended. Over.
Great, thank you.
Yes, I can see a question again from, I think, an anonymous person is asking about the level of implementation of Kenya EMR. Is it implemented nationally? So I'll just talk about the two implementations of Kenya EMR that is used in Kenya. So for COVID-19, we have a centralized instance of Kenya EMR deployed at the Ministry of Health Emergency Operations Center infrastructure, and the users from all the counties can access it remotely and securely. So it just depends on whether they have connectivity to access the resource and whether they have the right credentials for that. So the second implementation of Kenya EMR is specifically for HIV, TB, and maternal and child health. This is implemented as part of our project, Kenya HMIS2, that is heavily focused on HIV. And we have 43 out of Kenya's 47 counties using Kenya EMR and pushing data to the National Data Warehouse. So this is a distributed implementation. So each facility has a server that runs a Kenya EMR instance that they use for clinical care of patients at the site level. Over.
Great. Thank you for that information, Dr. Jacob. So what is another question here we have from from Harrison, Manaz Harrison. What has been achieved thus far in terms of the data in Nigeria?
Yeah, thank you. So in terms of data in Nigeria, what we have done is we have been able to set up emergency operation centers in about 22 states and counting. And in each of these states, the SORMAS platform, the SORMAS software has been installed and is being used to track the COVID-19 cases as well as for case management. In the states which we are currently supporting, that's about 8 states out of those 22 with the support of USAID. What we have done is we have hired consultants to work, strategic information consultants to work with the state incident managers as well as the state epidemiologists to look at that data on a daily basis. In some states, there is a daily brief that is being produced. In others, times weekly. That information is shared widely to state rapid response teams to enable them make decisions on a real time basis, as well as those reports are also shared are also forwarded onto the servers of the national the Nigeria Center for Disease Control, NCDC, where they are being aggregated at national level and also being used for decision making at that level.
Great. Thank you so much. So that looks like that's all the questions that we have on the Q&A. Let me check the chat. I do see a few more messages here. Okay, I think maybe, Fola, I see your question there, but maybe Dr. Jacob can follow up with you when they email. Oh, and he already did. Okay, so does anybody have any other questions before we wrap up today? It's been really exciting and interesting presentations to see how contact tracing and other data systems are being set up for COVID. Yes, we can. I see a question from Fola. We will send out the presentations and the link to the recording. We'll post all of that on the Global Digital Health Network website, and we'll send out the link to that information after it's posted. Any other questions? Okay. Well, I just want to thank again our colleagues from Palladium for being on the phone with us today and for sharing these wonderful presentations, and also to thank all our attendees for being here today. We will be sending out the recording for those who perhaps didn't get to attend today and the slides. We also want to remind you that the Global Digital Health Forum, which is run in December each year, is going to be virtual this year. So in case you missed it, the announcements, we have decided to move that to a virtual format. So we hope that everyone is still planning to submit abstracts. We have also pushed back our deadline for abstract submission to July 17th. So you'll have a little bit of extra time to prepare there. And we're also excited to be hosting be accepting abstracts in both Spanish and French this year as well. So please encourage your colleagues and your partners to be submitting abstracts. We're really looking forward to our new format this year and being able to really connect with everybody across the globe from where they're at and not have to travel. So thank you so much, everybody, for being here, and have a great rest of your day. Thank you.
Thank you. Bye.
Thank you. Bye.